It's not that the textbooks are correct, obviously, but it's not always cut and dry and clean, you know, the way the textbook present it. You know, we do this and it always works. Not really. But anyway, so I like to lecture to you guys because I think I can impart some clinical insight into things as we do this, which you know, kind of maybe will help you remember some things a little bit with what we're working. So stop me, very informal. Okay. If I read a definition or two, don't stone me. Some of these definitions need to be read because they're a little bit painful. All right, so we are going to talk about volatile anesthetic agents as well as nitrous oxide. So we'll go from there. So the ideal volatile anesthetic does not exist. They're getting better and better. And since the time that I've come in, I trained in the mid-90s. Sevoflurane had just come out at that point in time, as well as desflurane. So that was all a big step up in moving toward some of the things that we want to see with an ideal anesthetic, but they're still not ideal. There's some side effects and various things that, you know, but it's getting better and better. They don't explode anymore. That's a good thing. What we were always told in school, because I went to Georgetown for the 80s program, and they were always like, oh, the last explosion in the operating room with the volatile anesthetic was right here at Georgetown Hospital, and killed the patient and blew the anesthesiologist out into the scrub sinks. But he lived, I guess, but not. So these don't explode. That's a positive. That's a good thing. So as we go into the future, you guys will see more and more things come along, hopefully in your careers. That are pretty neat and big improvements in what we do now. I trained a lot. I trained with halothane and fluorine. We're going to talk about both of those. Halothane is kind of more historical now, although it's still one of the most widely used volatile anesthetics in the world because it's cheap. So in a lot of other countries, they'll use it. We don't tend to use it anymore, and I'll tell you what it was used for and what we have now that works just as well or better, which is why we don't use it. So I trained on halothane and fluorine, isoflurane. But now, and isoflurane is still widely available. You'll see that in all the operating rooms. But now everybody wants to use sevoflurane and desflurane, which is fun. But everybody thinks, oh, when we talk about some of these properties, they go away faster for various reasons that we'll talk about. So people think, oh, if it's a short case, you can't use isoflurane because it lasts a long time. Well, that was part of the art of giving anesthesia, which we learned when to turn it off, you know, a little bit earlier than the ones we use now. And it was an art. I mean, there really is a science to it, but there's an art to doing an anesthetic also, where you're not sitting in there for 30 minutes after the case ends because you overdid it and your patient's not waking up and the surgeon's kind of tapping his foot looking at you and, you know, you're waiting to get the next case in the room. So anyway, we'll talk about a little bit of history of this also as we go on. Okay, so ideal anesthetic would have very rapid onset when you turn it on, and then very rapid recovery or wake up when you turn it off. It's getting better. It would have no effect on the brain or other organs after the time of anesthesia. We're not there yet, although it's getting better. And you'll see why. It would be easy to administer. It would possess clear signs of the depth of anesthesia. Now, have they started talking to you guys about anesthetic depth and like signs that you would see, like how the eyes change and the breathing changes? And have you talked about any of that yet at all? That was really based on ether, when they used to use ether. It took a long time for people to go to sleep. They put this little wire mask on with gauze over it, essentially 4x4s, and they drip the ether on it. And the patient will go through all these physiologic changes. And they can tell the stages of anesthesia by looking at what the patient was doing. With our drugs anymore, that's not the case. But you want to know where you're at depth-wise on your anesthesia. We have various monitors and things like that. We watch your body cells to tell us that. It would have a high margin of safety for all ages, and it would be inexpensive, which we're not there. Okay, so when we talk about pharmacokinetics, we're talking about obviously the uptake or absorption of the anesthetic by the body, its distribution, its metabolism and elimination. And we'll go from there. So, uptake, you know what, I apologize. This slide on the right is notes. It's the next upcoming slide. So let me see how this looks, and then I'll give me a second to get unlost. There you go. Okay, so the brain and all other tissues of the body equilibrate with the partial pressure of the inhaled anesthetic delivered by the arterial into the arterial blood. So when you see these little, oh, you don't see my notes. Did he open that up yet so you guys can see my notes?
Yeah.
You see the notes on the bottom?
Yes.
Okay, that's everything that you need. Any questions that I wrote comes straight out here. Okay, so. So anyway, the large P with the small a is arterial partial pressure. The large P with the large a is alveolar partial pressure. Okay? So basically what happens is when you start inhaling an anesthetic, the anesthetic goes into your alveoli and then starts to go into your arterial blood. And pressures will equilibrate before you can have anesthetic available to deliver to the tissues, including the brain. And we're going to talk about those principles coming up regarding how the different agents are absorbed in different ways, some more than others. So sometimes it takes a longer time to go to sleep with one agent versus another because it takes longer for that equilibration of pressures to allow the agent to be available at the level of the brain. Everybody follow me with that? Okay. Okay. Okay, so what determines alveolar partial pressure? Well, input of the agent into the alveoli. When you, vaporizers work in different ways. Some of them have like a little screw thing on top, a dial that you will set to what you want to deliver. And our machines currently, it's all computerized, so you just use a touch screen and you put it in that way. Obviously, the more agent you give, you're going to achieve an alveolar partial pressure more quickly than if you give less agent, right? That's kind of true of anything. So we're going to talk about how we utilize that when we're putting people to sleep. So determines the partial pressure in the alveoli. How much agent are you putting into the alveoli? Minus how much agent is undergoing uptake by the arterial blood. So input, like we were talking about, is determined by what I dial in, okay? By how much I'm ventilating the patient. The faster and deeper I ventilate the patient, the faster that agent's going to move into the alveoli and thus into the bloodstream. And then uptake by the breathing system, okay? If you have a breathing system that has, like when we use extensions and have really long, like if we turn a bed 180 degree craniotomy on the patient, there's a lot more area for that agent to have to go through to get to the patient, so there's a lot of dead space. And I don't think so much anymore as much as it used to be when they used more rubber, but there would be uptake of the agent into the components of the breathing circuit itself. And so that would kind of suck a little bit of the agent that you were delivering out, and obviously it would take longer to get the patient to sleep because it was being stolen basically by the machine. I don't really know with our newer products that that's so much of an issue. So what we do initially, what you'll see most people do, although people do things in different ways, if you work with me, you'll see that, you know, I'm going to turn your dial up because you guys are going to be all, you know, oh, the MAC. What's MAC of acetylcholine? Anybody know yet? 2%.
Yeah.
Right? 2.1%. So you guys are going to say, oh, 2%. That's the MAC. That'll keep them asleep. You're going to turn it right to 2%. And I'm going to look at you and I'm going to turn it up to 6%. Because to get to 2%, if you set it at 2%, that's going through the breathing circuit into the lungs, and then some of it's being sucked up by the blood and actually absorbed by the blood. Okay, so you have to, and then it ultimately has to get to the brain to make you go to sleep. So you can look at the blood. I thought that this was described to me in a very good way when I was in school. The blood is like a swimming pool, and you have to swim. You have to fill the swimming pool up to where it starts to overflow, and before that water is available to the brain. All right. So as the swimming pool is filling up, that water is all staying in the blood or in the swimming pool, and it's not available to anything. It's just being absorbed by the blood. It's when you actually fill that reservoir that then agent will start becoming available to the brain as blood goes through the brain. It's like that extra agent will start to become available to actually anesthetize the patient. So if you set your vaporizer at 2%, because that's where you ultimately want to be, it's going to take you a long time to get there. Several minutes, 10 minutes, it just depends. It also depends on like how much oxygen you have flowing, how fast you're ventilating the patient, things like that. So I'll sit there and I'll look at you and I'll turn it up because I don't know my patient. We're going to get into that, but that's how we put people to sleep, usually propofol. And that will last for a bit, but then you get a big blood level of propofol and then it'll drop off. Well, as that's dropping off, your agent is coming on to substitute. Well, the propofol is going to drop off pretty quickly. If you keep your vaporizer real low, your vapor is just going to come up slowly. So we overpressurize, most of us. We'll turn it up and try to get the patient deeper faster. Everybody follow that concept? Mm-hmm. But you got to be careful, because then if you forget to turn back around and turn it back down, then you've overdosed the patient, and then you'll have hypotension, and that's all this stuff is going to happen to you. So that's why we're there, kind of looking over your shoulder, tapping you, saying, like, I want to turn that down, or whatever. So anyway, those are some of those concepts on uptake of the agent. All right. Uptake is influenced by many factors. How soluble is the agent in blood? And we're going to talk about all these separate volatile anesthetics and see the differences. The difference in the pressure, partial pressure in the alveoli versus the partial pressure in venous blood. What the patient's cardiac output is, and then something called the second gas effect, which is really theoretical. And you see you have a couple different definitions here. These are important to understand and know. But it has to do with using nitrous oxide, and we'll talk about this. A lot of people don't use nitrous anymore. I trained with nitrous. We use nitrous for everything. 70% nitrous oxide, 30% oxygen, and our whatever volatile anesthetic we were giving. But unfortunately, nitrous oxide is somewhat associated with nausea, vomiting, especially higher levels. So people have shied away from it, especially with the newer agents anymore. So the newer agents are less soluble in blood, so the onset, sevoflurane does where the onset is much quicker, and when you turn them off, they go away quicker. So we used to supplement isoflurane, which is more soluble in blood, with nitrous oxide. Then we could get less. So nitrous oxide goes away almost instantaneously, and then you just have a little bit of fluoride left to get off the patient, and they would wake up quicker. But because of the side effects, we still have it available, but even I kind of gradually got away from using it. Sometimes I'll use it, and it's kind of fun when I do, because I laugh. I'm like, God, I used to use this every day. And now I'll use it maybe a couple times a year. There are still some people who like it, but some people feel, again, that the association with post-op nausea is not worth it. Okay, so the concentration effect. This is the impact of the inspired partial pressure on the rate of rise of the alveolar partial pressure of an anesthetic agent. And in your notes, you can see that this is explained by Fick's law of diffusion. Nitrous oxide is 35 times more soluble than nitrogen. So more nitrous oxide will diffuse into the bloodstream from the alveoli than nitrogen can infuse back into the alveoli. Okay, so when you're given nitrous oxide, it's basically shooting into the bloodstream really quickly. 35 or 34 times as fast going into the bloodstream as nitrogen can come out of the blood back into the alveoli. So what ultimately happens is your alveoli kind of gets sucked down a little bit and shrinks, at least theoretically. Okay? And that keeps the nitrous levels very high in the alveoli, which maintains a very large gradient for the nitrous oxide to keep dumping into the bloodstream. So the concentration effect really is dealing with nitrous oxide. Everybody get that? Yeah? Okay. These are two concepts that are a little confusing. The second gas effect is based on Fick's law and the solubility of the agents. Again, because nitrous oxide is more soluble than nitrogen, it enters the blood more rapidly. That causes that little bit of shrinking down of the alveoli. The concurrently administered volatile anesthetic agent, let's say isoflurane in this case, maintains a higher concentration gradient in the alveoli because the alveoli is smaller. Now it's shrunk down. You don't need as much isoflurane to fill it up. Okay, so the uptake into the bloodstream ends up being faster because of that. So it's like the first gas, nitrous oxide, is kind of carrying the second gas, isoflurane, on its back to get into the bloodstream a little quicker. Okay? So two different concepts there. They're more theoretical than anything, and again, they have to do more with nitrous oxide, but still a good background for you to know. Okay, alveolar ventilation. Increasing ventilation will promote the input of the anesthetic into the bloodstream, which helps to offset the uptake of the anesthetic or the absorption of the anesthetic by the blood itself. The net effect is a more rapid rise of increase in the alveolar partial pressure toward the inspired partial pressure. That's what the PI is, inspired partial pressure. So you have a vaporizer, bless you. You turn on your dial to a certain level, 2%, right? So why does it take so long to get to 2%? Why is it instantly, you're breathing this stuff, why aren't you at 2%? Well, you have to get some of it into the alveoli. There's a partial pressure there that you have to get to. And then that's being sucked into the arterial blood, so there's a partial pressure there that you have to reach. And then that's being delivered to the brain, and then there's a partial pressure at the brain or a certain level that you have to reach to actually cause anesthesia to occur. So all of this takes time. Okay, it's like walking upstairs. I guess you reach this pressure, the next pressure, the next pressure, then you have anesthesia. So it's not a light switch. The opposite happens when you turn it off. How are most anesthetics metabolized?
Excreted through the lungs.
They aren't. Right, they aren't really. You'll see, like, you know, I think SIBO has maybe 5% metabolism. Desflurane, it's 0.02% on the lung. So it's not really metabolized. The only way you get rid of them is you have to breathe them off. Okay? So when you're sitting there waiting for a patient to wake up, which you all will do, and you're kind of like, oh, geez, you know, I turn this on 20 minutes before the end of the surgery, the guy's still not awake. It's because everything equilibrates, and we'll talk about partial pressures, but all of the tissues in your body are uptaking, especially the fat and muscles, are uptaking anesthetic agent. Okay, so you're building levels up in these tissues. When you turn the agent off, and the blood levels, the alveolar levels will start to drop. So then the blood levels will start to drop because the blood starts, they want to have equal pressures. So the arterial blood starts bringing more agent, or dropping more agent off at the alveoli. And where is that agent coming from? It's coming out of your tissues. Well, the tissues, especially the fat, that love to hold on to anesthetic agent. So the longer you're administering anesthesia, the heavier your patient is, various other things that are involved, the longer it'll take a patient to wake up. So you can't like have your agent on until 1 minute before, you know, they're putting the dressings on and you're going to wake them up and turn it off and he wakes up. Although I have had patients do that shockingly at times, but it's very rare. It's very shocking when they do too, like, holy cow. It takes 15, 20 minutes sometimes. And again, that's part of the art of trying to figure out, how do I know when to turn this off so that they come in for a nice smooth landing and the patient doesn't move or doesn't start to wake up when they're still suturing or whatever. And that happens, that's part of the, and the surgeons get, oh, especially the residents, he's moving, or they'll yell, he's waking up. I'm like, he's not waking up, man, he just moved the wheel. He's not gonna remember anything for another 30 minutes probably. So it would just, you'll see them, we got you. And sometimes it's okay. If you have some resident who's learning or an intern and they're closing, the patient moves a little bit, you know, well, like sometimes if you have a good relationship with him, he's moving. It's like, well, dude, it's taking me like a month to close. You know? So, but there's other times where you absolutely cannot have the patient move, you know, and so you have to sometimes you kind of err on the side of let them take a little bit longer to wake up, you know, and leave it on a little bit longer so that they don't. So again, you got to get your hands. You can sit here and read about this. You really have to get your hands on it, which you're going to start doing, and playing with it to see how cool it really is, and how it's just amazing. It's an amazing job. It's an amazing job because we get to give drugs that we see instantaneous pharmacological effects, and it's cool. It's really, really neat. We manipulate stuff every day, you know, blood pressure, heart rate, you get a little later on, but we get to see it come down right away. You get to see how things interact. It's neat. You're going to enjoy it. If you like pharmacology, I hope you like pharmacology, because and I hope you really need to know, and sometimes I'll divert off here, you really, really need to know, inside and out, up and down, autonomic nervous system pharmacology. You have to know it. You have to understand it, because that's a lot of what we do. A lot of the drugs that we give interact with the autonomic nervous system. A lot of the drugs we give will, we have to do them manipulated to slow the heart rate down or increase contractility or do whatever we're doing. You have to know autonomic pharmacology inside and out, so spend a lot of time on that. Okay. Solubility. Okay, so the impact of changes in alveolar ventilation on the rate of the increase in the alveolar partial pressure toward what you actually have dialed in, or the inspired partial pressure, depends on the solubility of the anesthetic in the blood. For example, changes in alveolar ventilation influence the rate of increase of the alveolar partial pressure of a soluble anesthetic, like halothane or isoflurane, more than with a poorly soluble anesthetic like desflurane or sevoflurane. Okay? That's because when you turn your dial on, sevoflurane and desflurane are not going to be absorbed as much. So you're going to get a quicker bang for your buck, basically. Okay? Halothane and isoflurane, they're bathing in the swimming pool, man. They're just hanging out, taking their time till the level gets to where something's available to the brain, because they're very soluble in the bloodstream. So by changing your alveolar ventilation, increasing your oxygen flows, increasing your tidal volumes, increasing your respiratory rate, you're going to have more impact on the soluble agents, because you're just basically throwing more into the pool to get it filled. Whereas the less soluble, they're all soluble, the less soluble agents, bless you, it's less impact because they're already becoming available more quickly. Okay. Hold on a second. The characteristics that influence the rate of rise of the alveolar partial pressure include the volume of the external breathing system. We talked about that. If you have extensions on, things like that, it's going to take longer. The solubility of the inhaled anesthetic in rubber or plastic components, and gas inflow from the anesthesia machine. So when we're waking patients up and when we're putting them to sleep, we run very high oxygen levels, 10 to 15 liters a minute, okay? Because it's partially going to help to deliver a lot more agent a lot more quickly. Then when we get to where we want to be, we turn the levels down, volumes down to 1 to 2 liters a minute. At the end of the case, when we start waking the patient up, we jack it all the way back up to 10 again to try to really flush the patient out as fast as we can, because it's that fresh gas flow that's going to get rid of that agent. Otherwise, it's just going to sit there and keep going round and round and round. So you have to do something to get rid of it more quickly. It's not metabolized. Okay. Now we're going to talk a little bit about these coefficients. Solubility, there's a blood gas partition coefficient, tissue blood partition coefficient, and then oil gas, which is not really something you have to worry about. Okay, so the solubility of the inhaled anesthetics in the blood and tissues is denoted by partition coefficients. Partition coefficient is a distribution ratio describing how the inhaled anesthetic distributes itself between two phases at equilibrium. So you'll have again, you'll have the blood gas partition coefficient. That is looking at the equilibrium between what's in the alveoli and what's in the bloodstream. Blood tissue is what's in the blood versus what's in the fat or what's in the muscle. Partition coefficients may be thought of as reflecting the relative capacity of each phase to absorb anesthetic agent. Okay, so blood gas partition coefficients. Numbers, what happened? Oh, you guys, I'm sorry. We don't, that's the next slide. Forgive me here. The next slide, there's numbers you need to know. Okay, so the blood gas partition coefficient. The rate of increase of the alveolar partial pressure toward what you have dialed in, or the inspired partial pressure, is inversely related to the solubility of the agent. The more soluble the agent, the longer it's going to take to increase your alveolar partial pressure. Okay. Agents that are listed are classified as soluble, very soluble, is methoxyfluorine, not really in use in this country anymore. Intermediately soluble, halothane, influrane, and isoflurane, and poorly soluble, nitrous, sevo, and desflurane. So the blood is a pharmacologically inactive reservoir for the inhaled agent. It sucks it up until it's full, and that agent is trapped in the blood and not available when the patient is asleep. When the blood gas solubility of an agent is high, a large amount of that, and that means it's very soluble, a large amount of the anesthetic must be dissolved in the blood before the arterial partial pressure equilibrates with alveolar. That's filling that swimming pool up. The swimming pool has to overflow for it to be available. The more soluble the agent, the longer that takes. The impact of high blood solubility on the rate of rise of the alveolar partial pressure can be offset to some extent by increasing the inspired partial pressure above what's required for maintenance. That's called overpressure. And that's what I was talking to you about. When you dial 2 and I reach over you and I dial 6 or 8, I'm overpressurizing to try to overcome that by dumping more agent in to fill the bloodstream quicker, basically to make it more available more quickly. Low blood solubility, that means that a minimum amount of anesthetic must be dissolved in the blood before that equilibration will occur. That's why you get such rapid onset with sevoflurane and desflurane and rapid offset with those agents also. Okay, this is what I was looking for. So numbers you have to memorize. You have to memorize. It doesn't work. Right here. Okay? These, I don't think anybody's going to ask you about those. You should understand what they are. But the ones you really need to know, like when I'm working with you, if you're going to turn on sevoflurane, you better know what's the MAC, what's the blood gas partition coefficient, what's the vapor pressure. I mean, there's only 1, 2, 3 plus nitrous that we even use anymore. It's 4 agents times 3 numbers each. I mean, it's not very many numbers that you have to memorize. So you don't want to come in, and I'll go a little off track again. Don't come in and start using drugs that you don't know about, okay? This can be, anesthesia school, anesthesia training can be very straightforward and not easy, but very, maybe, well, I don't want to say, it can be very straightforward, okay? If you prepare, if you read about your drugs, you study your drugs, you memorize your drugs, you come in. If you're going to give phenylephrine or ephedrine, I'm going to ask you, like, how does it work? And if you can't tell me how it works, like, what are you doing? Like, how can you pick that drug up and give it when you don't know how it works? So we're going to give you a list of drugs you need to memorize them and know how they work. It's very easy to stay out of trouble with people if they see that you're reading and preparing, okay? So when you go to turn on desflurane, I'm going to ask you what the MAC is. If you don't know what the MAC is, I'm going to say, well, then how the heck do you know how much you have to give to put the patient to sleep? You know, it's like giving any drug. You don't know the dose, but you're going to give the drug. Here's like 10 million milligrams of Motrin. You'll feel better. You'll be dead, but you'll feel better. You have to know that basically the dose. This is the dose, and we're going to talk about. Well, that's not the dose. The MAC is the dose, but we're going to talk about that. You have to have those memorized. Okay. Read about your cases before you go in. Sounds stupid, right? But you're going to run into Miss Thomas over there. She's retiring in March. She's done like 42 years over there. She's about this tall. She's great. She's a great teacher in the heart room. But when she comes out shaking her head and she's like, the student's upset with me. I'm like, why? Because I yelled at him. Well, why'd you yell at him? Because we're doing an aortic valve repair and he knows nothing about aortic stenosis. Well, the valve repair was being done because the patient has aortic stenosis. Critical aortic stenosis absolutely impacts the anesthesia and what you do for it. And this student, he didn't read a thing. So you can't get upset that they're upset or we're upset with you. You know, that's just expected. It's crazy, isn't it? It's crazy that would happen. So don't let it happen, you know? And if you come in, all that student had to do was read. And come in, they don't have to know everything. They just had to read and be able to say, well, this is what aortic stenosis is, and you know. And she would have been happy. At least they're preparing, you know. We don't expect you to know everything, but we expect you to put that effort in. So things like this, you got to memorize the numbers.
Good question.
Sure. Now, you know what? I don't feel like it. Hey, nobody's in field like this, right? Yeah. Oh, look at that big thing, recording. So, go ahead.
The partition coefficient, so it's at 37 degrees centigrade, right? So does it change the temperature, this coefficient?
Somewhat maybe, but not anything big that's going to be, you know. Now, I mean, most of what we do is going to be at about that temperature anyway. If you get into real extremes of temperature, that's a good question. That's a good question. I'll try to find out the answer for that. I don't know, like if you're outside in the Arctic or something, I don't know. That's a good question for, like, me being military, we have to look at things like that. We might be in the extremes of temperature trying to do anesthesia, but I will find out about that. I don't know. It's a good question though. If I don't know, I'm going to tell you I don't know. Okay, so I was on the slide with the numbers, right? Okay, this is another depiction of how this works. So, basically, the alveolar fractional pressure rises toward your inspired pressure faster with nitrous oxide. You see how quickly that happens? Vice methoxyfluorine, because nitrous oxide is not soluble. So when you put it into the alveoli, almost immediately fills the blood and gets to the brain. Vice methoxyfluorine, which is getting sucked up by the blood and sucked up, it just takes its time getting to a level where you can actually get anesthesia at the level of the brain. So just another idea of it. Okay. Again, just another slide with numbers. Okay. But again, the blood gases are the primary ones I want you to be concerned with. Okay. Blood tissue partition coefficient determines the uptake of the anesthetic into tissues and the time necessary for equilibration of the tissue partial pressure with the arterial blood partial pressure that's delivering the agent to the tissue. The brain is the end target for your inhalational anesthetic. The concentration of agent at the brain is reflected by the concentration of the agent in the alveoli. Okay? So, when you look at your monitors and you're administering anesthesia, you're going to see an inspired fraction of the anesthetic, and then you're going to see the exhaled fraction of the anesthetic. Which one's the wrong important? What's the one that you're looking at for how deep the patient is? Exhale, because that's reflecting, that alveolar partial pressure is reflecting what's happening at the brain. Okay? So when we look at MAC, and you turn the dial to 2%, and maybe you're delivering 2%, you're going to see, when you look at those numbers, it's going to tell you, oh, they're at 0.5%, 0.6%, 0.7%, and it'll gradually go up. That's what's happening at the brain, okay? So if you want to run a MAC anesthetic, it's got to be end-tidal agent that you're looking at, all right? It's not what you're delivering. Setting the dial at 2% doesn't mean you're delivering a MAC, okay? You have to leave it there for quite a while. And again, with all the other things we're talking about, how fast you dilate, things like that, will get there quicker. And ultimately, they will equilibrate. What you're delivering, the inspired partial pressure and the alveolar partial pressure will equilibrate. So after, if you're in a case for 6 hours and you have 2% SIBO on, gradually you'll see 2% reflected as your inspired agent, and gradually you'll get up to 2% as your end-tidal agent also, because the blood's absorbed what it's going to absorb. The tissues have, the muscles and fat. Well, fat will absorb for a long time, but they will equilibrate over time. Yes?
So is that the exhaled agent is probably what you look at when, say, you're overpressuring, right? Like you're talking about where you go up a little bit and you watch it exhale until it comes up to your target, and then you maybe just turn it back down.
Right.
Okay.
Because I'm worried about
the loading dose.
I'm worried about my end-tidal agent.
Right.
Because that's telling me the patient's asleep. Okay, among other things.
Okay.
So that's what I'm targeting. It's not what I have dialed in. So you can dial in 8%, and it'll say, you're delivering 8%, but that's not what's really happening in the patient's brain. Okay? But it'll get there pretty quickly, so then you have to remember to back down, or then you're going to be delivering an overdose of agent. So everybody's got that, right? That's why we can sample with a mass spectrometer. We can sample what the patient is exhaling and get an end-tidal agent level, and that reflects what's happening at the brain level and how asleep they are. Okay? Yes?
So will the exhaled equal the inspired once the whole body has reached?
Well,
or
yeah,
will it still be going?
You'll see it before then, because, and you might be within like 0.1 or whatever, because the fat will absorb and absorb. The fat can absorb for what they say for days. This fat can absorb in a second. So you never really fill all the reservoirs, but you'll get your end-tidal and your inspired agent levels will get pretty close. But you really kind of have to be there for a while for that to happen. Okay. All right. And that's right. Fat is an enormous reservoir that will keep sucking in agents. So when you have patients who are really obese, sometimes it takes them longer to wake up because they absorb, they hold on to the agent longer, and then the agent, you know, as the blood level, when you turn it off and the blood level starts to drop, then basically, because of the equilibrating factors, the agent will start to pour out of the fat back into the bloodstream and be circulated to the lungs to be exhaled. It takes a while for that to happen, okay? So something that has to be taken into consideration. But all patients do not react the same. That's what I was saying. You know, just because I've had patients wake up on, like most patients, MAC awake, the definition of MAC awake basically is about end-tidal agent of about 0.2%. Okay, like sevoflurane. When you get somebody down to around 0.2% exhaled when you're waking them up, usually at that point they'll start to wake up. But I've had patients wake up way more than 0.5, 0.6 MAC. Most patients will be well asleep and finish it. Hey, Bob, surgery's over. And you go, wow, holy crap. Now, why is that? Why is that? Is that because this guy drinks like a bottle of wine every night, or he drinks a fifth of Jack Daniels? People are different. Everybody's metabolism is different. Everybody reacts differently to the agents. So, you know, this is all again textbook stuff. But just because somebody tells you the MAC awake is usually around 0.2%, that doesn't mean that that's the same for everybody. There's a lot of factors that go into, some of which we don't understand, that go into how the patient wakes up. Oil gas partition coefficients, we're not going to worry about that. All right, nitrous oxide. We already said 35 times more soluble than nitrogen, so it will enter air-filled cavities faster than nitrogen can escape from that cavity. So if you have a compliant wall cavity like the intestine, a pneumothorax, an air bubble, what's going to happen? It's going to expand, okay? Because all that nitrous is going into that bubble 35 times faster than nitrogen can come out of that bubble. That can cause big problems. If you have a pneumothorax, the pneumothorax is just going to get worse. Or if you have, well, I can recall very distinctly times when the surgeons will say, hey, can you turn the nitrous down? Because they'd have the intestines maybe running the bowel, and the bowel would actually start to, they wanted to blame everything on nitrous. We were like, yeah. So some cases we would run nitrous. Tympanoplasties, which is basically putting a graft over a ruptured eardrum. Today, I probably would not use nitrous at all for that. But in training and when I was first practicing, we used nitrous. We just had good communication with the surgeons. And they would say about 45 minutes out from them actually doing the graft, they'd say, okay, we're 45 minutes out. And they would turn the nitrous off at that point because by the time they put the graft in, it would dissipate, okay? If we were still running nitrous, what could potentially happen? You blow the graft out because the ear has air in there. The pressure starts to, that air starts to increase, pressure increases, you blow the graft out. So something, you know, that was one of the things you had to know. So if somebody comes in with a pneumothorax, you're not going to put them on nitrous oxide. Okay. All right. How does cardiac output influence anesthetic uptake? Well, it does influence anesthetic uptake, and therefore the alveolar partial pressure by carrying away either more or less anesthetic from the alveoli. If you have increased cardiac output, you're going to get more rapid uptake of agent into the bloodstream, okay? And then it's going to take longer for the actual anesthetic to be induced. That almost seems counterintuitive, doesn't it? If you have more rapid uptake, why aren't you going to sleep faster? Well, basically, more cardiac output means you're delivering more fresh blood through the lungs, and that fresh blood is there saying, you know, it's sucking it in and holding on to that agent so it's not available, okay? So higher cardiac output, more fresh blood delivered through the alveoli, more agent is being absorbed into the blood, it takes longer to go to sleep. If cardiac output's lower, then the blood that's rolling through there is rolling through more slowly, and ultimately absorbing less, so the agent becomes available quicker to the brain. So when might that be applicable?
So a patient with heart failure that's got decreased cardiac output?
Right, absolutely. Absolutely. Elderly patients too, oftentimes will have lower cardiac output. So You gotta be careful when you're putting elderly patients to sleep. Advice, we have to be careful with everybody. But it's a little bit different putting an 85-year-old to sleep than it is a 20-year-old. You don't necessarily overpressurize and jack it up because they're going to react differently to it because of that. So, but yeah, decreased cardiac output states, congestive heart failure. You have to think about that. They have slower cardiac output. It's going to take longer to get them to sleep. The other thing you have to remember with that low flow states is that when you give a drug, you have to give it time. Okay, so sometimes you put somebody to sleep. I see it all the time with elderly. You'll get some docs that will come in and they'll push the entire stick of propofol. And the next thing you know, you have an 85-year-old who's hypotensive, you give them vasoactive drugs to treat them, and that it didn't necessarily have to happen. People who understand geriatric patients and do anesthesia on the elderly will very gently induce them, and a lot of times, a full stick of propofol with 200 milligrams, a lot of times you get away with 50, 60, 70 milligrams of propofol. You have to give it time though, because it takes time to circulate out of these patients to get to the brain. It's going to take a lot longer for an 80-year-old to circulate that propofol to their brain than it's going to take a 20-year-old. So you kind of have to be more gentle and give it more time. They just have slower circulation, so you got to give more time to go to sleep. Okay. Tissue uptake. Highly perfused tissues, like the brain, heart, and kidneys, are less than 10% of your body mass, but they receive about 75% of the cardiac output. That's called the vessel-rich group. These will equilibrate very rapidly with the arterial partial pressure. Now, once they are full, basically, you'll still have continued uptake of anesthesia, and that's reflective principally by the agent being absorbed into the muscle and the fat. So the vessel-rich group will get quickly absorb the anesthetic and get full. All right. Here, 10% of your body weight, 75% of your cardiac output. Okay, so very high perfusion. Whereas after that's full, the muscle and fat will still keep absorbing. All right, so you can see by relative solubility that the fat can just absorb and absorb and absorb and absorb almost like forever. Okay, but much lower perfusion, so it takes longer for those groups to be filled. And this is just another depiction of that. When you turn the anesthetic on, here, the alveoli will get filled first, then the vessel-rich group, then the muscle group, and the fat group never really gets filled. Neither does the muscle group really. Okay? When you turn the anesthetic off, your alveolar and arterial vessel-rich group levels will drop most quickly. Okay? So the patient will start to wake up, but they're still putting anesthetic agent into their system from the muscle and fat into the bloodstream for a much longer period of time after they wake up. So when they go to recovery room, you have to remember that there is still agent, and sometimes you can smell it when patients are waking up. You know, if you're close to them, you can smell them exhaling, and these agents have a very distinct odor. So you can tell that they're still exhaling this because it's coming from the muscle and fat. Even though they're waking up, you don't metabolize any of it, so it takes a while to get rid of it. Yes?
So generally, do you increase your fresh gas flow
At the
anytime
end?
you increase your anesthetic flow? Your anesthetic percentage?
Oh, well, sometimes.
Or
Depends on
is it-
what's going on in the case. Not always.
Okay.
I mean, if I want to deepen a patient up, that's what you're talking about. Like we're in the middle of the case, I set him at a target level, and then, we're watching the patient, various monitors, and they stimulate the patient for some reason or another. So you'll see the blood pressure go up, you'll see the heart rate go up, and you'll realize that that's usually a sign of light anesthesia. Okay, the patient won't remember anything as long as you have them deep enough. They won't remember, but it's a sign that they're feeling pain. These agents will decrease pain, but they won't totally take pain away, which is why we give narcotics as part of what's called a balanced anesthesia technique. Volatile anesthetics is only part of that. We give volatile anesthetics, we give muscle relaxants, we give narcotics, things like that to try to cover all of our bases. So if you have a patient who, let's say, is, I don't know, they're having a total hip done or something or other. You have them set and everything seems to be going fine. You've given some fentanyl narcotic. You have them set a MAC of anesthesia, 2% entitled anesthesia. And then all of a sudden the patient's heart rate goes up and blood pressure goes up. Usually that's an indication that they did something that caused pain. Okay, so how do you treat that? Well, there's various ways. You can give narcotics. If you haven't given narcotics in a while, you can just give narcotics. But usually most of us will deepen the anesthetic agent up, which is what you asked about. So when we deepen the anesthetic agent up, do I always turn the flows up to get it on faster? Not necessarily. It depends on how the patient reacted, okay? If the patient moved, let's say that we're doing a case and they do something and the patient bucks or coughs a little bit, yeah, we dial everything up. Boom, as high as you can go, and then usually we'll supplement with propofol, because propofol through the IV will very quickly get them back deeper, okay? But other times, if their heart rate just went up a little bit, and you can see it, and you're like, man, they're probably not quite deep enough, I'll turn the agent up, I'll give a little narcotic, and I'll just kind of wait it out. Usually that's all you have to do. So that was a good question also. All right. Recovery from anesthesia is depicted as the rate of decrease of the brain's partial pressure as reflected in the alveolar partial pressure. At the conclusion of the anesthetic, the concentration of the inhaled agent in the tissues, the fat and muscle especially, depends highly on the solubility of the drug that you gave and the duration of its administration. Okay? The more soluble the drug, the more is going to be absorbed in the tissue. It's going to take longer to get rid of that. So it's going to take longer to wake up, right? And time is a factor also. The longer you're doing the anesthetic, the more is going to be absorbed. When you turn it off, the longer it's going to take to wake up. So people will look at you and say, oh, sevoflurane, desflurane, you turn them off and they wake right up. Not necessarily. If you run sevoflurane or desflurane for hours, we'll do cases sometimes that are 15, 16-hour neuro cases. And if you run an agent that long, it's going to take them a while to wake up. You're not going to turn that off and they're going to wake up. It's going to take a while. And if you're running something, sevoflurane that's less soluble, at least they'll wake up a little quicker. If you're running isoflurane that's very soluble, it's going to take them a lot longer to wake up. And that's where the art comes in, where you have to figure out, when am I going to turn this down or when am I going to turn it off, and balance between the patient not moving and not being aware and not experiencing discomfort versus them being asleep for 45 minutes after the procedure's done. And if you want to piss a neurosurgeon off, have a patient asleep for 45 minutes after the procedure's done. The first thing they want to do is the neuro exam to make sure that there are no problems. So they're kind of they're the light switch ones a lot of times. Okay, it takes a little bit of time. So I always kind of look at it like flying a plane. When you're coming in for a landing, you can either, if you turn the gas off too short or too fast, and the patient moves or bucks, you hit the trees on the way into the runway. And if you leave it on forever, you hit the trees on the other side of the runway. And what you're looking for is a nice landing where, ideally, you'd like to wake the patient up. And it happens. It's very satisfying when it does. When you can time it to where the last dressing goes on and they start taking the drapes down and you say, hey, Bob, and he opens his eyes and looks like it. Open your mouth. Put your mouth up, you exudate it. That's beautiful. It's a beautiful thing. That's like the Holy Grail. It's like, and anybody who says that they routinely hit it, I will tell you straight out, they're full of something. Are you guys good? Do you need to stretch or anything? Okay, we gotta move on. Actually, it'll get faster after these concepts are over with. Okay. So. At the conclusion of the anesthetic, the concentration of the inhaled agent in tissues, we just said it depends on solubility and how long you were getting the anesthesia. So there will be continued passage of anesthesia from the blood to the tissues, such as the fat, that helps to speed the rate of decrease of the alveolar partial pressure. So what that means is, even though you turn the agent off, you have to breathe it out. You have to breathe agent off to get rid of it. We're saying that, right? But the fat will help you to wake up a little bit sometimes. Sometimes it doesn't. If somebody's really obese, they're really dumping a lot of agent back in. But because the fat never really fills up, when you turn the agent off, the fat will keep kind of taking some of it out of the bloodstream. So that's helpful. You're getting rid of some of it that way. Although you're not getting rid of it, you're getting it out of the bloodstream, but away from availability to the brain. And then you're breathing off the rest of it. But it takes a while. Patients are not like wide awake after surgery. It takes a while. You can't just wake them up and send them home right away. You gotta watch them for a little while because that agent is still, even when they're in recovery and they're waking up, like I was saying, sometimes they'll still smell it because they're still dumping it from their fat into the bloodstream at a very low level, not enough to keep them asleep. They'll wake up, they'll cooperate with you. A lot of times they won't remember. All right. I had a ACDF done in January, and I don't remember anything. It was awesome. I don't remember anything. Somehow they said I was helping them get my X-rays in the recovery room. I moved myself onto the bed to go upstairs, and I woke up and my wife was there, and I'm like, "What the hell time is it?" I don't remember anything. Well, I mean, this was. I woke up in the room. That was a solid, probably hour and a half after the case was done, and I don't remember anything. So I still had agent on board, you know, as well as some of the other drugs that they were giving. I'm sure they loaded me up quite a bit with other stuff. I picked my CRNA and I told him to shut me up. So don't let me say anything. So he said that as soon as he gave me the verse that hit, I started singing. And I remember, so we were singing. I don't know why, that's what was there. And he said as he was taking me, I started to talk to people in the hallway, and he said he already had the propofol line, pushing it to shoot me up. So by the time I got in the room, I don't remember, from the time he pushed the Versed, I remember nothing. So it was great. But why did it take me so long to wake up? It wasn't the Versed. That Versed was given hours. Yeah, and the surgery probably took 5 hours. So the Versed was given 5, 6 hours. That's long gone. And it wasn't the narcotics, you know, so it probably was agent that was left. So where was that agent coming from? It was coming from here, unfortunately. Okay. So anesthetics absorbed into the breathing system components are also going to pass back of those components. When you turn the gas off, right, now no more fresh agent is going through the breathing circuit, so anything that's absorbed is going to start to want to equilibrate, so it starts to dump back into the fresh gas. So you're rebreathing some of that agent. Like in the soda line, you'll all understand what soda line is. Yeah. It gets rid of the CO2 so we can rebreathe gases, saves a lot of money, warms the patient. But they'll rebreathe some of that agent. So we use little techniques to try to help us out with that. Turning the flows way up helps. And then sometimes we'll do what's called flushing the circuit, where we'll disconnect the circuit from the patient, and we will block it, occlude it with our thumb, and try to with oxygen out the scavenger system to try to get rid of some of whatever might be in the circuit, to flush it out through the scavenger system and suction, so that the patient doesn't keep getting exposed to it. And so, does it work? I don't know. Sometimes it seems to work, sometimes it doesn't. Sometimes it's just a tincture of time. Okay, so we are on to way behind. So you can see here that it says fresh gas flow rates need to be at least 5 liters a minute at the end of the case to help them not rebreathe. We usually turn up to 10 or 15 per minute. Okay, factors that influence a more rapid emergence from the anesthetic: high fresh gas flow rates, lower tissue solubility of the agent. The lower the solubility, the faster it's going to go away, and shorter anesthetic times. If you have it on for 20 minutes for a minor procedure, it's going to go away very rapidly. If you have it on 6 hours for a procedure, it's going to go away more slowly. Diffusion hypoxia. This occurs when inhalation of nitrous oxide is discontinued abruptly. So you turn it off at the end of the case. So it leads to a reversal of the partial pressure gradients, right? So you're no longer putting nitrous oxide into the alveoli. So your alveoli is now kind of empty of nitrous oxide. The pressures want to equilibrate, so it goes backwards and starts dumping from the arterial blood back into the alveoli to be breathed away. But what can happen with diffusion hypoxia is, because it is so, it'll enter the alveoli 34 times more quickly, so you'll flush the oxygen out to an extent of the alveoli, basically. You'll flood the alveoli with nitrous, you'll have less oxygen, patients can become hypoxic, okay? So that's why you'll see that we usually take patients from the OR to the recovery room with a nasal cannula or face mask on, with a reasonable flow of oxygen, to help to keep fresh oxygen in their alveoli to offset that. It usually only lasts 5 to 10 minutes. It's done. Okay. Pharmacodynamics involves the receptors, responsiveness to the drug, mechanisms of action of a drug, and what the drug actually does to the body. Okay, so minimal alveolar concentration of the agent. This is defined as that concentration at 1 atmosphere that prevents skeletal muscle movement in response to a noxious or painful stimuli, such as incision, in 50% of patients. So it's the ED50 of the anesthetic agent, okay? So that's basically the dose. How do you know what the dose is? It's the dose, it's the ED50. Now this is done with, remember we're giving a lot of other drugs too. So when they do a surgical stimuli, we have narcotics on board. There might be some residual propofol depending on how fast things happen, things like that. So we have drugs that help us with this, but if you were just giving a volatile anesthetic and you set that, you waited and waited and waited until the patient was at an end tidal of 1 MAC of the volatile anesthetic, 2% SIBO in tidal, and then they did a surgical incision, 50% of patients will not respond to that, 50% will. That's the definition of MAC. Okay? Each agent obviously has a different MAC. It's the most useful index of the anesthetic equal potency, and there's various impacts of physiological pharmacologic factors that impact the MAC that you'll need to memorize. They're important. Okay, so for instance, increasing age results in progressive decrease in the MAC of about 6% per decade. That's similar for all anesthetics. So really elderly patients, like we define the MAC of SIBO as 2%, right? But it's not that for really elderly patients. What is it? Kind of hard to say, but you have to remember, I don't have to have them at 2% to know I'm at a MAC. They need less typically, because the MAC requirements decrease. Whereas on neonates and infants, typically run a higher MAC, so 2% might not be enough for them. They might need 2.5–3% of anesthetic. Their MAC tends to be a little bit higher.
I have a quick question.
Mm-hmm.
So elderly, their cardiac output is lower, you said, right? So they require less of the agent?
Right, because remember now that the blood that's going through the alveoli is moving slowly.
Slower.
So it is kind of maybe already filled up with anesthetic agent or getting full. So whatever you're giving is more available to work at the brain, okay? So, all right, hold on. Slower cardiac output. Oh, sorry. Let me step back on that. We said higher cardiac output exposes more fresh blood, absorbs more agent. Lower cardiac output, the blood is already exposed to agent, okay? So they will actually go to sleep a little more quickly based on that. But the cardiac output also takes its time delivering the agent to the brain. We were talking about 2 different things there. We were talking about inhalation agents, and then we were talking about IV drugs. IV drugs with lower cardiac output, it's going to take longer because the blood has to actually circulate from the IV to get it all the way to the brain.
Gotcha.
And if I give it to you, it's going to be pretty quick. If I give it to an 80-year-old, it might take an extra minute or so. And my point there was you have to take your time and know that and be gentle with your induction. With these agents, they're actually exposed a little more quickly, but we're not typically putting people to sleep by just breathing them down with volatile agents. Usually you're using a combination.
So do you give them a little bit more of the anesthetic agent?
No, because we put them to sleep with IV drugs.
Oh,
okay, so we get them to sleep with IV drugs typically, and then we will.
But if we were to just give them inhalation agent, they would require a little bit higher dose?
Well, again, they have lower cardiac output, right? So their blood has more agent available, so you could actually give a lower dose technically from the start. But we still have to overpressurize to get that dose on board, okay? So I still would turn the vaporizer up to get them to sleep. If I'm doing their anesthetic, I'm not going to start at 1.5 or 2% of SIBO. I'm turning it up, and I'm going to get them up to what I think their MAC requirement will be. I'm going to guess if it's an 80-year-old, maybe they have 1.5 as their MAC instead of 2. So I'm going to turn it up, and when I start approaching 1.5, I'm going to back it off, okay? Whereas if it's you that I'm putting to sleep, I know you're at least a minimum of 2% for your MAC in tidal agent. So I'm going to keep you turned up for longer, okay? But either way, I still have to turn that dial a little heavier because even old people are going to absorb some of that agent into their bloodstream, just not as much as you are, okay? Does that make sense?
Mm-hmm. Yeah.
All right, so back. Increasing age results in a decrease in the MAC. MAC values are additive, okay? So if you're running nitrous oxide, 50% nitrous oxide, that's 50% MAC essentially. So you can run, and let's say you're running sevoflurane with it, then if you get to an end-tidal of 1% sevoflurane, half a MAC, plus that 50% of nitrous oxide, those two add together to make a full MAC, basically, so it's additive, okay? So that's one of the benefits of running nitrous oxide, is that it gets on very quick, it goes away very quick. You can run less volatile agent, which is more absorbable, right? It stays around longer. So when you turn your agent off at the end, you have a lot less agent, you have a lot less soluble agent to get rid of if you use nitrous oxide along with it, which is why we always mix those together. It's kind of a great technique. 70% nitrous oxide, we could give maybe 0.4, 0.5 MAC of the volatile agent, and that was enough. And at the end of the case, that's all you had to get rid of, was 0.5, 0.4, 0.5 MAC of SIBO instead of a full MAC of SIBO. So less agent to breathe off. That's the idea of that. But again, you're not going to see it that much. I hope you do get exposed to it. Okay. So these are, you need to remember the structures of the agents, okay? Again, there aren't that many, so you need to be able to draw these. Why? Honestly, can I draw those right now? No, I'm not in school anymore. So you have to memorize them and understand what the differences are between them, okay? Why does one explode and one doesn't? Yes?
Real quickly, just to make sure I have this right. So we said that nitrous oxide is 35 times more soluble than nitrous, nitrogen, but that's just in air spaces, like in the alveoli. That's not in the blood.
No, it's in the blood also.
Okay, so then how does it have a low blood solubility?
Well, it's not more soluble in the blood. I guess what I should say is it's got very low solubility. It just goes in and out of outer spaces quickly.
Okay.
Right.
So it's like quick solubility.
Right. So if you look at the alveoli as a balloon, and it's full of nitrous oxide, and the nitrous oxide starts to escape, it's going to go out 34 times faster than if you were trying to put nitrogen into the balloon. Nitrogen to get in there, so that balloon is going to start to shrink. That's how the alveoli shrink, and you get that concentration effect. Okay. So yeah, that's not solubility. That's more movement in and out of air spaces.
Okay.
Okay.
Like diffusibility?
Pardon me?
Like diffusibility or something like that?
Like yeah. Actually, yeah. It would be diffusion. Right.
Well, and think about the volume of agent that you're using as well. Like you give a lot of nitrous, and so that volume of it. So compare the blood gas coefficient of DES, which you're only giving volume per volume like 6%, as opposed to like nitrous, which is like its MAC is 105. And so you're just giving a lot of nitrous, and so a lot of gas diffuses into these other spaces, like the bowel and the ear.
Right, and it does happen before your eyes when you use it.
Or the cup.
So yeah, it's kind of neat because nobody does it anymore, so you won't see it. You won't see the bowel swell up, Or you won't get yelled at because like somebody gets a pneumo and somebody turns around and says, "You still have the nitrous on?" And then you turn it off and grab it. Yes. You probably won't experience that. Okay. So we are on for this. So anyway, the MACs are on here. You have to memorize those. You have to memorize the vapor pressures. Okay. Vapor pressures involve the agent inside a vaporizer. It's pretty hard to make mistakes anymore with filling vaporizers. It used to be that you would just fill out the vaporizer and you would pour the agent in there. You could pour water in there, you could pour coffee in there, whatever you want, right? But anymore, they have safety mechanisms now, okay, where, because accidents have unfortunately happened. Do you ever hear the term, or you will hear the term, green gas is good? That's oxygen, all right, because oxygen comes in green, the cylinders, you know, and the lines that come in with oxygen are green, okay? And the couplets that hook into the anesthesia machine are a certain size, and they have these little pins on them that are in a certain place, so you can't accidentally connect a blue gas is nitrous oxide. You can't accidentally connect it to an oxygen source. It's happened. They had a couple patients die a number of years ago in a hospital when they didn't have that system set up. They thought the person who was giving the anesthetic thought they were giving oxygen, and the patient died of hypoxia because it was nitrous oxide. Somehow, behind the scenes in the wall, engineering was in there and they mixed the lines up or something. So now they have all these systems. But one of the systems we have is that you cannot, well, you can get by any safety system. People do dumb ass stuff, excuse me. When you find like a, we have what's called a pen index safety system. Have you heard of any of this yet?
Yeah.
All right, so do you know the pen?
Yes.
What are the places?
2 and
2,
5
5,
for
and 3, 5,
oxygen, and
right?
3, 5, and 1
Right.
5 for air.
Good, so gotta know those numbers, all right? When you look at it, but that's how they're placed. Well, people will file those off. They'll file those little pins off, and then you can still put a tank of whatever against the input and tighten it up, and it'll go. So I've never seen that, but when you learn about dumb things that happen in anesthesia, that's one of them. So people always try to get around things for whatever reason, even though they're set up. Color coding is very important. All of the anesthetic, all the volatile agents are color coded. Isoflurane is purple. Sevoflurane is yellow. Okay, so when you go to fill the vaporizer will have a yellow, entry point, and then we have these little tubes that we hook up to the bottle with like little pin index safety system things on them. So a nitrous bottle, when you open it up, it's got a little neck on it that has like little stopper points, so that you cannot take an isoflurane tube and connect it to that sevoflurane bottle unless you break that plastic thing off, because it won't fit on there. Okay. Same thing the other way around. And then the opposite end has a little device that slides into the vaporizer to fill it, and they are shaped differently. So you shouldn't be able to take a sevoflurane vaporizer filler and connect it to a desflurane vaporizer or an isoflurane vaporizer because it won't fit. Okay? Whereas in the past, you just unscrewed it, and you poured the coffee in, and you were good to go. So vapor pressures were important, and you need to know the numbers. If you put and you can't really do it anymore, but it's just historical. If you put a lower vapor pressure agent, influrane, into a higher vapor pressure vaporizer, isoflurane, so you accidentally somehow dumped influrane into an isoflurane vaporizer, and you turn that dial on instead of that 1%, are you going to be giving a higher concentration or low?
Lower.
Right, easy to remember that. Low into high gives you low. High into low gives you high. Okay, so that's why that's important. We used to have machines in the military. I still have one of the wheels because it's historical. You cannot get them anymore. But our vaporizers were basically, you could pour anything. And then you mentioned about temperature. We would have to set, so actually this answers the question. This dial, we would dial in the vapor pressure of the agent we were using and the temperature of the environment we were in. And then it will give you, like when you're set at this on the dial, this is what you're delivering. So you can put anything in that vaporizer and use it in any environment, but you had to know that, you had to adjust this like wheel thing, cardboard wheel thing we had to know exactly what you were giving. So I just saw it the other day, I was going through something, I'm like, oh, that's really slow. We don't have those machines anymore. Trying to get away from that, because quite honestly, if you didn't know what you were doing with it, and they were never FDA approved, because nobody else uses it except us. So we always had to get special permission to try to set one up to teach people how to use it. That's always kind of interesting. Okay, so you gotta memorize that stuff, all right? Okay, so this is probably maybe one of the most important slides in the lecture, okay? Trying to tell you, but you have to know this. And it's really not hard to learn this. Okay, so there's variables on the left and their effect on the MAC. So hypothermia, both extreme hypothermia and moderate hyperthermia are going to decrease the MAC, except if your temperature goes above 42 degrees Celsius, they say it'll increase it. Age, the young have a higher MAC, the elderly have a lower MAC. Alcohol, acute intoxication, they're already half anesthetized, so you need less MAC, right? Whereas if they're a chronic alcoholic abuser, they're going to need a higher MAC. Those are the patients sometimes, that's what I was saying, you turn the agent off, and then you're at a half MAC, and everybody in this room probably, except for like, I don't know, that guy, he's probably drinking heavy. You're probably going to wake up about 22 MAC, but that guy doesn't feel awake like this. Sorry, I had to pick on someone.
No, pardon me? I'm what? I'm a Mormon? What?
Oh,
Yeah.
oh, sorry, I thought you said a Corbin. I was like, I shouldn't have picked that name.
No, there's plenty to make fun of.
But anyway, so chronic abuse is the requirements, because basically they're they need more. Okay, anemia, interestingly, a hematocrit less than 10% lowers the MAC. And we have a lot of patients where I work that come in with hematocrits less than 10%, trauma patients. You know, they come in. I was just talking to somebody the other day that I hired from Michigan. She's awesome. She has 6 kids, 3 of them are triplets. She's unflappable. Hey, Liz, you know, like 10 hours just exploded. Oh, yeah? So I'm like, she's just amazing because she's got all these kids at home. It's like, whatever. You didn't get run over by a bus today? Good deal. So, anyway, she said when she came from a level 2 trauma center to us. And it's kind of shocking when you do that. I came from a naval hospital, which was mostly ASA 1s and 2s, some 3s, to Shands, which is a lot of ASA 3s and 4s. And I'd see people come in just like she did. We were laughing yesterday about this. You know, I had a crit of like 7. Holy crap. And now we're like, hey, their crit's above 6, bonus. A lot of them, that's how they come down. So that will lower the MAC. PaO2 of less than 40, you're in trouble. They're already getting anesthetized at the brain because they don't have enough oxygen. So it's going to lower the MAC. No change with any thyroid conditions. PaCO2. Really high PaCO2 is an anesthetic, has anesthetic type effects. So when you're waking a patient up, you don't want to just sit there. Like part of what we do when we're waking patients up is we work on trying to get them to breathe on their own. So we will actually turn the gas off, turn the respiratory rate down a little bit to let their CO2 start to build so that their hypoxic drive kicks in and they start to breathe. And then we titrate narcotics to their respiratory rate. So if somebody starts waking up and they're breathing 30 times a minute, you're going to start to give narcotic because usually that's an indicator that they're having some pain. And you're going to try to get them down below 20, maybe 15 to 20 before they wake up so they're more comfortable. If they're only breathing 6 times a minute, you know you don't need to give any more narcotic. Well, when they're only breathing 6 times a minute, a lot of times their CO2 will sit pretty high. And then people will be like, well, why aren't they waking up? Well, because CO2 acts kind of like an anesthetic. So you need to, so a lot of times we'll put those patients back on the ventilator and blow their CO2 down and let them wake up that way. So really high CO2, lower MAC. Hypercalcemia decreases it, hyponatremia increases it, hyponatremia decreases it. You just got to remember that. Pregnancy decreases the MAC. Pregnant women do not need as much anesthetic agent. Decreases by 1/3 at 8 weeks gestation. Now, that's for textbooks, okay? But it does decrease in pregnant women, so you don't need as much MAC. And then drugs. Okay, local anesthetics tend to decrease the MAC, except for cocaine. Opioids decrease the MAC. All right. If we're giving opioids, that's gonna help to control their pain, so you don't need as much agent on board to deal with that. Ketamine decreases the MAC, barbiturates, benzodiazepines. So what increases the MAC? Almost everything is a decrease here, right? So what increases the MAC? Acute sympathomimetic use, cocaine use, and ephedrine will all increase the MAC, okay? Ephedrine, I don't know, we give ephedrine all the time. We don't really take that into consideration so much, but per the textbooks, it increases the MAC. Acute cocaine use, they're all hopped up when they come in usually. So it takes more to get them to sleep. They have a higher MAC. So that's a great chart, very useful. Okay, so we're gonna start moving into individual agents and then we'll kind of move quicker, okay? Mechanisms of anesthesia, we can go through this. How does it work? Nobody's really 100% sure how it works. There's various theories, molecular and cellular mechanisms, voltage-gated ion channels, ligand-gated ion channels, the Meyer-Overton theory, okay? But the mechanism is really not known. Molecular and cellular mechanisms, most drugs act by binding directly to proteins. And there's evidence that inhaled anesthetics may act the same way. It seems unlikely that voltage-gated sodium, potassium, or calcium ion channels play a substantial role. Ligand-gated ion channels may be important, and that involves GABA. That's very possible that that's where things are happening. Okay, the Meyer-Overton theory, I think I get into that next. No? The Meyer-Overton theory, or critical volume hypothesis, basically looks at a correlation between the lipid solubility of the agent and the potency of the anesthetic agent, and that's historically been presumed to have an impact, okay? But again, nobody 100% knows. Okay, Meyer-Overton. Dissolved anesthetic molecules expand between the lipid cell membranes, so the cell membranes move a little bit, close off sodium channels. Maybe that's how you go to sleep. The protein receptor hypothesis, or agent-specific theory, is suggested by the steep dose response curve and loss of the anesthetic property with increasing molecular weight of the agents. Microcrystalline theory suggests that anesthetic gas forms microcrystals, which may interfere with nerve conduction. And then there may be an alteration in neurotransmitter availability, and that involves GABA. So again, that's there for background, just so you have that. Okay, nitrous oxide. Now we're going to go into individual agents, and we'll kind of move along here. Okay, everybody with me?
Yeah.
Yeah. Everybody want to stretch? Go to the bathroom? No? All glad to be here?
Yeah.
I'm glad to be here. Damn glad to be here. It's Friday. What the heck, right? All right. Nitrous oxide is the only inorganic gas that's still in clinical use. It's the least potent of the inhaled anesthetics, and we know that because the MAC is like real high, right? 105. Can't really reach a MAC of nitrous oxide, or the patient will be dead and very unsuppressed. It's non-explosive, non-flammable, but it will support combustion. It's a gas at room temperature and ambient pressure, but it's stored as a liquid under pressure because its critical temperature lies above room temperature. Now, when you look at an oxygen tank in each cylinder, right, and you follow that little, how many liters of oxygen are in each cylinder? Okay, so if you go down to 300.
Sorry. I was trying to look something up, and then the ad came on. Yeah.
I'll wait on it.
No. I was trying to look something up, and the ad came on. Sorry.
If you have an oxygen tank, right, you can watch the valve and know, is it 3/4 full? Is it half full? And actually, there's 2,000 liters in each cylinder, because we always have them on the back of the machine. You turn them on. I'm sorry, 2,000 psi, 650 liters. You can tell, I don't do this. 650 liters, 2,000 psi. You can follow the psi to tell how full the tank is, right? If it gets down to 1,000 psi, half the oxygen's done. Is that how nitrous works?
No.
No. Okay, because it's liquid in there with gas on top of the liquid. Okay, so when you're looking at the pressure, you're seeing a reflection of basically the gas that's left in there, and so it'll sit at what? Does anybody remember what the pressure is? 750, right? Yeah. And it's going to sit there, and you can think, oh, this is great, this is full, and then next thing you know, as soon as all the liquid is turned into gas, boom, there goes the pressure, and you have an empty tank. So it's liquid and gas, so it doesn't work the same way. Okay. So how do you know how much is in it? You gotta weigh it. Obviously, you have to weigh it out. They might do that at whatever company it comes from. Okay, so that's why. Cardiovascular-wise, it tends to stimulate the sympathetic nervous system. It directly depresses myocardial contractility in vitro, but arterial blood pressure, heart rate, and cardiac output are essentially unchanged when you're giving it to a person, and that's because it stimulates catecholamine release. Okay, so you might get a little direct depression of the myocardium, but the blood pressure, heart rate increase offset any hypotension. It constricts pulmonary vascular smooth muscle, very important. So it increases pulmonary vascular resistance. So who maybe do you not want to give this to?
Right sided heart
Patients with
failure.
pulmonary hypertension, all right, because you're worsening possible right side. Right. It increases endogenous catecholamine levels, so how much norepi you're putting out, so it may be associated with an increased incidence of epinephrine-induced dysrhythmias. So you're given this drug, and then the surgeon injects a local anesthetic with epinephrine in it, and you pick some of that up in the bloodstream, you might start to see some dysrhythmias more quickly if this is on board than if it's not. Okay, respiratory-wise, it increases the respiratory rate, so it causes tachypnea, decreases the tidal volume, and that's related to CNS stimulation and perhaps activation of pulmonary stretch receptors. But then when the patient undergoes surgical stimulation, that tends to increase their minute ventilation, and they increase tidal volume and respiratory rate, so it offsets that. The net effect is a minimal change in minute ventilation. Hypoxic drive is markedly depressed with nitrous oxide, okay? And that's a serious implication of the PACU. So not only do you have washout or diffusion hypoxia occurring, where all of that nitrous is flooding into the alveoli, pushing the oxygen out so they can be hypoxic, but in addition to that, their hypoxic drive is decreased, so they're not breathing as much anyway. So you need to put oxygen on them and watch them for a few minutes. But again, this is transient, usually goes away very quickly. All right, cerebral effects. It increases cerebral blood flow and cerebral blood volume, so that'll cause a mild elevation in intracranial pressure. So you're probably not going to use it in neurosurgical or cranial type cases. All inhalational agents increase cerebral blood flow. So some do it less than others, and you'll see that as we go on. So if we're in a case, a neuro case, a lot of times we will use sevoflurane, but oftentimes anymore what most people do is they'll run what's called a total IV anesthetic, or a TIVA, where we run a propofol infusion, a narcotic infusion, and maybe no volatile agent at all. I tend to like to run maybe 0.2, 0.3 MAC of agent, kind of as a safety mechanism, makes me feel better, because I always worry with total IV anesthesia, you know, in a lot of these neurosurgical cases, the patient's arms are tucked, what if the IV blows, you know, something like that happens. At least you have something on board to help to prevent recall. So, but again, different people do it different ways. Okay, it does not provide significant muscle relaxation, and it's probably not a trigger for malignant hyperthermia. Renal-wise, it decreases renal blood flow by increasing renal vascular resistance. Again, this is all in the notes, or you guys will have this. Hepatic blood flow probably decreases, but to a lesser extent than with true volatile agents. And again, it's been associated with post-op nausea and vomiting, probably from stimulating this chemo receptor trigger. Biotransformation, really, as you can see there, essentially none of it is metabolized. You have to breathe it off. It inhibits enzymes that are vitamin B dependent, including the thymine synthetase, which is needed for DNA synthesis. That's one of those things that will stand out as a board type question. If they're, you know, those are the little different things that stand out, you got to know them. It also causes bone marrow depression. If you have prolonged exposure, it could cause that. And it could cause neurologic deficiencies such as peripheral neuropathies and pernicious anemia if you're exposed to it for a long period of time. So again, something specific for that agent that you want that. Possible teratogenic effects. Again, contraindications, we already talked about the solubility, or really the diffusibility is what you should say of the agent. Thank you. It diffuses in air spaces more rapidly than nitrogen can diffuse out, so you don't want to be giving it somebody who's had maybe an air embolism, pneumothorax, acute intestinal obstruction. Do you want to be giving it then? No, because that's going to be blowing up and making it pressure even worse. You can blow the intestine out. Intracranial air, pulmonary cysts, intraocular air bubbles. Okay, so if you're in the eye clinic and they're doing a retinal repair and they put an air bubble in, you don't want to be putting nitrous in there because that's going to go right to that air bubble and increase pressure in the eye. And then the tympanic membrane grafts we talked about. And again, you avoid pulmonary hypertension because it'll make it worse by increasing pulmonary vascular resistance. Drug interactions, it's frequently used in combination with more potent volatile anesthetics, and it does potentiate neuromuscular blockade a little bit. The MAC is 105%. Blood gas solubility, 0.47. Okay, what does that mean? Blood gas solubility. It's low solubility, right? So it's going to be very available very quickly because not much of it is absorbed in the blood. So remember that chart with the, or that picture with the, it's going to very quickly rise to the level where you get anesthesia. Halothane, I love halothane, but it's really not around anymore. When sevoflurane came out, we used to use halothane to induce children primarily. That was primary use for it when I was in training, because we didn't really have sevoflurane was coming out. And most of these agents smell really bad. So if you smell isoflurane, you're not going to lay there, especially if it's a kid, and breathe that. Okay. Sevoflurane has a sweet smell to it, so they tolerate that better. Halothane's the same way. It wasn't pungent. It didn't make you cough. It smelled okay, so patients tolerated it. It's a halogenated alkane. Its carbon fluoride bonds are responsible for it being non-flammable and non-explosive. It's in amber-colored bottles because it undergoes spontaneous oxidative decomposition. So there's a preservative in it called Volatile to help to prevent that in the amber-colored bottles. It's the least expensive volatile and still used in many places around the world, but not really by us. It causes dose-dependent reduction of arterial blood pressure due to direct myocardial depression. It's the one, most of these agents, when you give them, will cause decreased blood pressure, okay? How does that happen? Why does the blood pressure go down when you give a volatile anesthetic? For most of them, not this one, so you already have a clue there.
SVR goes down.
SVR, okay? You decrease the SVR, you basically vasodilate the patient, you drop their blood pressure, okay? Fluorine, sevoflurane, isoflurane, sevoflurane, desflurane, that's how they do that. Halothane, it's a direct actual depression of the myocardium. It's a coronary artery vasodilator, but coronary blood flow overall will decrease related to decrease in systemic arterial blood pressure. But adequate myocardial perfusion is usually maintained since the oxygen demand drops. You know, when you decrease myocardial activity, you're going to decrease myocardial oxygen needs. And it does inhibit baroreceptor reflexes. Direct myocardial depression may be from interference with sodium-calcium exchange and intracellular calcium utilization. Halothane inhibits the baroreceptor reflex response. Normally, hypertension is going to inhibit the baroreceptors of the aortic arch and the carotid, causing a decrease in vagal stimulation and an increase in heart rate. Halothane will blunt that impact, okay? So you get hypotensive and your heart rate doesn't pick up to help out with that situation. It slows conduction at the SA node, which may result in junctional rhythms or bradycardia. It sensitizes the heart to the dysrhythmogenic effects of epinephrine. So doses above 1.5 mics per kilo, they don't have to memorize that, it's just there for background. That should be avoided because they'll start to have dysrhythmias potentially. And systemic vascular resistance is unchanged with the drug. When we put kids to sleep with halothane, we'd always have our precordial stethoscopes on, listening to their heart and watching the cardiac monitor. And it was awesome because they would breathe and they would go to sleep, and then you could actually hear the myocardial depression ensue. You could hear boom, 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 then you hear boom, boom, like the sound changed, and the more you listen, the more you pick that up, like wow. And then you'd look up and you start to see a PVC, another PVC, and we'd reach over, turn the halothane off. They were asleep by then, and then we turn the fluorane on. So once you're asleep, you can use any agent that you want. So that would be the end of us. That's what we tell them. Get them to sleep initially, because kids usually have to breathe them down. They're not going to tolerate an IV. So in a lot of situations, we just put a mask on, let them breathe themselves down. So the halothane, they tolerated it, worked pretty quickly. But then as soon as we heard the heart sounds changing and started seeing its rhythms, we turn it off, turn the other agent on, and it usually would resolve pretty quickly. So kind of cool. Okay, respiratory-wise, causes rapid shallow breathing. The apneic threshold, which is the highest PaCO2 where a patient will stay apneic, rises. So in other words, you need more CO2 to stimulate breathing when you're on this. It limits increase in minute ventilation that would normally accompany a rise in PaCO2. Spontaneous ventilation may cause sympathetic stimulation and lead to vasodilation in these folks that are on this. Hypoxic drive is depressed, again, a problem in the PACU especially. It's a potent bronchodilator, so when patients were in status asthmaticus, sometimes they would intubate and actually leave them on an anesthetic, leave them on half-life for a while because it would relax the bronchioles after that. And it depresses mucociliary function. So again, that hurts with post-op hypoxia and atelectasis. So when you add, that on top of the fact that it's decreasing respiratory drive, you can get hypoxic. Cerebral effects: it lowers cerebral vascular resistance and increases cerebral blood flow by causing vasodilation. Cerebral autoregulation is blunted. Do you guys know what cerebral autoregulation is yet? Have you talked about that yet? Your cerebral blood flow will autoregulate itself in certain ranges of blood pressure, usually between a mean of 60 to 160 millimeters of mercury. If you keep a patient's blood pressure there, it depends. But their arterioles and venules in the brain will open and close to keep the blood flow at a certain particular amount, of usually 50 milliliters per 100 grams of brain tissue per minute. It's in Morgan and McKeown. When you look at the neuro chapter, it's right at the beginning. It's kind of a cool concept, but that's where it is. Well, that can be blunted by halothane. So it's not an agent, again, I'm going to use it in neurosurgery. It does cause an increase in intracranial pressure, but they always taught us that if you hyperventilated the patient before you turn the halothane on, that would offset that. Whether or not that's 100% true, but that's what the test was like. So that was a standard standard technique for us. So if we were using halothane, we would hyperventilate the patient first before we turn the agent on. And cerebral activity is decreased, so you'll get a moderate reduction in cerebral metabolic rate of oxygen utilization. Do you know what coupling and uncoupling is? Again, terms you might not have heard yet. Cerebral blood flow and cerebral oxygenation are coupled, or typically coupled, right? So if you increase need for cerebral oxygenation, cerebral blood flow will increase to give more oxygen to the brain. So they're coupled together. Increased metabolic needs, increased blood flow, okay? That's good. With some of these agents, you'll decrease cerebral blood flow. Well, not volatiles, but other agents, IV agents, you'll decrease cerebral blood flow. You never want to have uncoupling, where you decrease. A bad uncoupling is where you decrease cerebral blood flow, but you increase cerebral metabolic rate of oxygen needed at the brain. That's a bad thing because you're not delivering what you need. If you go the other way around, which is what's happening here, you get a little bit of increased blood flow at the brain, and at the same time, you're decreasing the demand for oxygen at the brain. That's fine because you're delivering more oxygen than you really need. So that's the concept of coupled blood flow and then uncoupling, okay? Questions? No? All right, neuromuscular-wise, it does cause some muscle relaxation, and it potentiates non-depolarizing muscle relaxants. It is a trigger for NH. NH, malignant hyperthermia. If you don't know it, you'll learn it. The only real disease caused by anesthetic exposure, and it's usually the volatile anesthetic agents are the real trigger for it. It reduces renal blood flow, glomerular filtration rate, urinary output, and basically all inhalation agents will lead to decreased urinary output. It does cause hepatic blood flow to decrease, and the metabolism of some drugs and the clearance, fentanyl, phenytoin, appear to be impaired. It's oxidized in the liver by cytochrome P450 systems, and it has been, this is important, halothane hepatitis, this is called. It's been associated with some hepatic dysfunction. And it's the most commonly associated of all volatile agents with liver dysfunction, and that again is called halothane hepatitis. It's extremely rare. It occurs in about out of 35,000 cases. It's usually patients exposed to multiple halothane anesthetics at short, quick intervals. Middle-aged obese women tend to get it, and persons with a familial predisposition. Signs include elevated liver lab values that are there, encephalopathy, elevated bilirubin. It's a centrolobular necrosis that occurs, and it might be possible liver damage that occurs from reductive metabolites or hypoxia. The important thing to know is that it really was only associated with halothane. So typically if somebody had liver problems, you're not going to use halothane. Contraindications, as we just said, no compelling evidence really that it worsens pre-existing liver disease, but most people wouldn't use it. Caution with intracranial mass lesions, you have to be careful with all of the volatile anesthesia, anesthetic agents with intracranial mass lesions because they increase intracranial pressure. And if you start increasing intracranial blood flow with these agents, that's just going to worsen intracranial pressure. So it's something to have to be careful about with neurosurgery. Negative inotropic effects and sensitizes the heart to chemical energy. Drug interactions. The myocardial depression may be exacerbated by beta blockers or calcium channel blockers. Tricyclic antidepressants in NAOIs are associated with blood pressure fluctuations and dysrhythmias. And if you're using anenophyllin along with it, they can cause dysrhythmias. Okay, the MAC. You gotta memorize these, right? MAC is 0.75. Blood gas solubility 2.54. Which is relatively high, which means it's soluble. The higher that number, the more soluble it is. Vapor pressure 243, 15 to 20% metabolized. You need to remember how much of each of these agents is metabolized also, okay? Methoxyfluorine. Methoxyfluorine used to be used, and I heard, I don't know if they're actually using methoxyfluorine or not. I heard in Australia, it's either coming back or they're still using it, where for labor analgesia, they used to give women a mask. And when they had a contraction, they put the mask on because the contraction makes them hyperventilate. And basically go out. It was methoxyfluorine. And then they stopped breathing methoxyfluorine, contraction would resolve, they'd kind of come to again. And then when the next contraction came, they breathe it. So, and I've heard that it's still kind of in use out there in some places. So, not here. It's a halogenated methyl ethyl ether. This is all background. We don't use this agent anymore. You probably, I don't even know if it exists. Sweet fruity odor, non-explosive, non-flammable. It is the most potent volatile agent. You don't have to get much of it to get a bang for your buck. Very high solubility and very low vapor pressure limit its rate of induction. So it takes a long time to get on board to cause anesthesia. Depresses cardiac contractility, lowers cardiac output and arterial blood pressure. Does not affect the barrel reflexes. It will cause increased respiratory rate, increase the respiratory rate, but decrease the tidal volume. So you get a decreased minute ventilation overall. Resting PaCO2 will rise, and it's got some bronchodilating properties, but they're mild compared to alpha. It does vasodilate cerebral vasculature. It does cause some skeletal muscle relaxation, does decrease renal blood flow, and post-operative high-output renal failure was a distinguishing feature in some cases with this drug. And it does decrease hepatic blood flow. Extensively metabolized by cytochrome P450. Oxidative metabolites that occurred with this drug included free fluoride. Free fluoride is nephrotoxic, and they would get a vasopressin-resistant, high-output renal failure, so they couldn't concentrate, they would just dump fluid. Okay, that's something different with this drug, so probably something that you want to remember. And then there's a number there. Free fluoride ion levels of 50 micromoles per liter is the threshold for renal dysfunction, and that's nice, whatever that 50 micromoles means. Importantly, though, that level can be achieved in only 2.5 to 3 MAC hours of exposure. So if you're running this agent at a MAC for 2.5 to 3 hours, they could potentially start having renal issues. So, all right, contraindications, nephrotoxicity, any degree of renal dysfunction is a clear contraindication. And you want to maybe avoid in patients, you're never going to see it, but avoid in patients receiving nephrotoxic drugs. So the MAC, 0.16. Okay, what's the MAC of SIBO? 2%. What's the MAC of ISO? 1.2. What's the MAC of Desquite? 6%, right? So you don't have to give much, that's 0.16%. Okay. Blood gas solubility is 12 though, that's pretty high, so it's very soluble. 22.5 vapor pressure, and 50% of the drug is metabolized. That's a lot. Influrane. I got to use this in training, and I'm not that old. No, I hate it. It didn't go away that long ago. Like I said, I was in training in the mid-90s, and I did cases at a VA hospital, and I worked with an anesthesiologist who loved Influrane. He loved it. So I got to use it there. And most of them, quite honestly, when you're using them, besides having to know the doses and what you're giving, I never really noticed any real big differences. You know, I mean, the textbooks will tell you that there are a lot of differences, and there are, but it wasn't anything that I really like, oh my God, I used influorine in this guy's, like, this happened, by isoflurane. Halogenated ether, mild sweet odor, non-flammable at clinical concentrations. I don't know what non-clinical concentrations are. Depresses myocardial contractility, arterial blood pressure, cardiac output, myocardial oxygen consumption are lowered, decreases the SVR, and the heart rate usually will increase. The depressed myocardial contractility involves suppression of calcium influx. And sarcoplasmic reticulum release of calcium during myocardial membrane depolarization. I love when you get on these chains and, you know, everybody starts chiming in. Okay, respiratory-wise, increased respiratory rate, decreased tidal volume, kind of a theme across these agents. Overall decrease in minute ventilation, increased rest in PaCO2, decreased response to hypercapnia, sounds familiar, right? Abolishes the hypoxic drive, depresses mucociliary function, causes some bronchodilation, and may cause marked respiratory depression. Increases cerebral blood flow in ICP, so not for use in neurosurgery typically. This is different with influorine, and something that, again, if a board question is going to come up on it, it increases secretion of cerebral spinal fluid, and it causes resistance to cerebral spinal fluid outflow. So that's going to increase intracranial pressure. Okay, that's different about this agent than none of the others do this. And it also has epileptiform activity and has been seen to cause frank-tonic clonic seizures. So both of those are different things about this drug that don't occur with the others. So you might want to realize. They all relax skeletal muscle. Okay, and in some cases, that's all you need. If you're doing like an ankle fracture, a malleolar repair, you don't need a lot of skeletal muscle relaxation because there's not a lot of muscle there that they're working with necessarily. So you can just run the volatile agent and not really give them any more muscle relaxation. You might give them succinylcholine or something just to intubate them so the cords aren't moving, and then after that you let it wear off and you don't have to give any more. But if you're doing a big bowel case, with all that abdominal musculature, the volatile agents will not give you enough muscle relaxation to allow the surgeons to comfortably operate. They'll be in there and they can tell. Sometimes they can't, sometimes they can't. Sometimes they'll tell you they can't. Is he relaxed? No, you'll learn how to deal with that. But we give supplemental muscle relaxants, IV muscle relaxants, to supplement what's happening with the volatile. Or the volatile really is very, very minimal. So we have to give IV agents to help out with that. Okay. Have you gone through any IV classes, drug classes? Have you talked about rocuronium? Or it's just way too early for this stuff, you guys. Well, you will. You're going to see that there's a wide variety of different muscle relaxants that we give, and there's various reasons for giving them. That's one of them. Okay. Decreased renal blood flow, decreased hepatic blood flow. Fluoride is an end product again with this drug, but defluorination is much less than with methoxyfluorine, so you don't really see that renal dysfunction. So obviously, contraindications, you may avoid it in patients with pre-existing renal disease, certainly with seizure disorders, and precaution with intracranial hypertension, you wouldn't use it. It's not a drug that you would pick. And INH can cause more defluorination. Again, you're probably never going to see it. MAC is 1.7, blood gas solubility 1.9, vapor pressure 175,000. All right, isoflurane. These are the three drugs now that we're getting into that you're going to actually use. I apologize for this. It's a chemical isomer of influrane, non-flammable. It's got a very pungent odor. You can't really breathe a patient down on isoflurane. It doesn't work. They cough, they buck. It doesn't work. It causes minimal cardiac depression in vivo. The cardiac output is maintained by an increase in heart rate due to partial preservation of the baroreflexes. It causes mild beta adrenergic stimulation, and that's going to increase skeletal muscle blood flow. It decreases the SVR, and it overall lowers arterial blood pressure. And if you give nitrous oxide along with it as a substitute, you'll offset some of that effect. The increase in skeletal muscle blood flow that you see with this drug does not occur with the other ones. If you rapidly increase the level, you'll get a transient increase in heart rate, but not to a lesser extent with desflurane. Remember I talked to you about overpressurization in terms of vaporizer up? You gotta be careful doing that with desflurane, because if you do that, patients tend to get a little tachycardic. You don't want the little old lady from Pasadena getting tachycardic, because then they're gonna use more myocardial oxygenation and you're putting them at risk for aggravation. So you have to be careful with that, but these will react that way. There's something called coronary steal syndrome. They think that isoflurane dilates coronary arteries, and basically coronary steal means that you have two coronary arteries, one that is stenosed already and one that can dilate. If you dilate that coronary artery, which is usually, if it can dilate, it's usually going to a part of the heart that's been preserved. This one cannot dilate. Blood starts to flow more through the dilated vessel to areas of the heart that already have adequate blood flow, and maybe it gets stolen away from the stenotic areas that are already at risk or have been through it in line. Okay, so that's called coronary steal. It's diversion of blood to the vessels that can dilate, theoretically. Okay, respiratory depression, similar to the others, except the tachypnea is less pronounced. The net effect is that you'll get a more pronounced fall in minute ventilation with this drug. It blunts the normal response to hypoxia and hypercapnia. They all do that. It's a good bronchodilator, but again, halothane is the most potent bronchodilator. It increases cerebral blood flow and intracranial pressure at concentrations greater than the MAC, but it's less pronounced than with halothane and influrane. It reduces cerebral metabolic oxygen rate. They all do, because your brain goes to sleep, so you don't need as much oxygen flow because there's not as much activity occurring there. And if you run a 2 MAC, you'll actually see isoelectric activity or no activity on an EEG. And so that may actually instill some cerebral protection in certain situations. It does cause some skeletal muscle relaxation, it does decrease your blood flow, and it does reduce hepatic blood flow. It's metabolized to 1/10 the extent of influrane. Nephrotoxicity is extremely unlikely. It's not an issue with this drug. And there's really no hepatic dysfunction problems either. And the only contraindication is if you're really worried about coronary steal, but again, that's theoretical. The MAC is 1.2, and the other numbers just need to memorize them. Metabolism is 0.2%. So when we get into the newer agents, very minimal metabolism, you have to breathe them off. Desflurane. The structure is similar to isoflurane. The only difference is substitution of a fluorine atom for isoflurane's chlorine atom. That is magic in my book. I don't know how they do that. All right, vapor pressure is 681 milliliters of mercury at 20 degrees Celsius. So it boils at room temperature at high altitude. So it's delivered by a special heated vaporizer. So when you touch your vaporizers on your machine, you'll notice that the desflurane vaporizer is plugged in and it's actually pumped up. Very low solubility, so rapid onset, pretty rapid offset. Blood gas coefficient is 0.42. That's actually lower than nitrous, which is 0.47. So it's the most rapid onset, input and offset. However, again, if you're on it for a long enough period of time, you're not going to wake up like that. It's going to take a while for it to wash out. Very high vapor pressure, very ultra short duration of action, and moderate potency are its characteristic features. Cardiovascular effects are similar to isoflurane. All three of the newer ones, iso, SIBO, DES, are all pretty similar with all of these. Blood pressure drops because of decreased SVR. Cardiac output remains relatively unchanged. Moderate rise in heart rate, CVP, and PA pressures. And again, very rapidly turning up the concentration causes transient elevation of heart rate, blood pressure, but you don't see it as much with isoflurane as you might see with desflurane. I'm sorry, you see it more with desflurane than you do with isoflurane. Again, decreased tidal volume, increased respiratory rates, so the minute ventilation does not really drop, and you'll see a little bit of a decrease in alveolar ventilation and a rise in resting PaCO2. It's pungent, you can't breathe somebody down with it, so no inhalational induction. It directly vasodilates the cerebral vasculature, so you don't usually see this used in neurosurgery. Increases cerebral blood flow in ICP at normal tension and normal capnia. Markedly decreases the CMRO2. It says ICP can be lowered by hyperventilation, but we tend to avoid it. Cerebral oxygen consumption is decreased. And it's no nephrotoxic effects, no hepatic injury effects, and it does cause a little muscle relaxation. Minimal metabolism. It does become degraded if you have desiccated carbon dioxide absorbance into carbon monoxide. Basically, potentially clinically affects if you did that for a long period of time. But our absorbent, our bare line is color. It becomes colored when it becomes expired, basically. Okay, so it turns like a bright purple. So we change our carbon dioxide. It's not sitting there forever. We change it out quite frequently. So the chance of something like that happening is probably contraindications: severe hypovolemia, malignant hyperthermia, intracranial hypertension. That's the same for all these drugs. You're not going to give a volatile anesthetic agent to somebody who's severely hypovolemic because they're going to vasodilate and it's going to make it even worse. Okay, when you get trauma patients in, it's unfortunate that we can't get IV scopolamine anymore. Because when you get a trauma patient in and they're bleeding out, you can't really put agent on it. I mean, all you can do really, you have to hope that they're not going to remember anything just because of the trauma and the hypotension. You can't really turn volatile agent out because you're just going to worsen the situation. So we give them muscle relaxants, we give narcotics if we can, and we resuscitate them with blood, platelets, etc. FFP. But we used to have IV scopolamine, and we would give them 1 dose of IV scopolamine, and it would scramble the eggs for quite a while. Like they wouldn't remember anything. 24, 36 hours, they wouldn't remember anything. It was a beautiful thing. Just give them scopolamine. Well, we can't get it anymore. I don't think they're even making it anymore. They make patches, but they don't make, if they made it, we wouldn't be able to get it, so I guess they're not making it anymore. I don't know why they stopped making it, I guess. Why they can't make that. But it's a shame for us because we're wearing traumas now. We're like, man, that was just such a benefit to have, and now we don't have it. Okay, there's the numbers: 6% MAC, 24.2 blood gas liability. SIBO, this is the first drug we're going to talk about, so bear with me, okay? It won't be much longer at all. Like desflurane, halogenated with fluorine, blood gas solubility slightly greater. What's the blood gas solubility of SIBO? 0.65. Some will tell you 0.69. When you look at different sources, you'll see a little bit difference. That drives you nuts. What do I remember? 0.6, 0.7. No. So that's not that big thing. But for you guys, you have to know the numbers. So when Mr. Self comes up, Dr. Self now comes up, ask him what number he's going to be looking for on the test. So you say you know, all right, 0.69, 0.65. Hopefully, you won't get questions like that. Blood gas solubility slightly greater than DES. Non-pungent and rapid increase in alveolar anesthetic concentrations make it an excellent choice for smooth and rapid inhalational inductions in pediatrics and adults. It has fast emergence, but there have been some cases of pediatric patients waking up with delirium afterwards. That's where patients basically thrash around. They don't know where they are, and you have to hold them down. It's kind of, just going to happen right now. With adults, sometimes we'll do a little propofol or a little Versa to get them through that period of time. There was one anesthetist that he wasn't a very likable guy, and he was waking that patient up when I was in the Navy. This guy was like a Marine or a Navy SEAL or something. Patient had some delirium, and he came up like this. He didn't break his nose or anything, but he blooded him up a little bit. And it was kind of funny because you go, oh man, that's too bad. It's terrible, but it's kind of fun. So we learned to, I had one case with a student, God bless her, this is the last story I'll say because we're dragging. We had a Marine, we would get these young guys, they would wake up delirious quite a bit. So we had to be kind of loaded for bear with some of these guys. And so this guy's waking up and he's punching and thrashing and I had propofol brought up and I told the student, get the propofol, and it was like slow motion. She drops it. And I'm like watching as it spins and it lands right on. Of course, there's nothing on it. It's open. lands right on the floor. And I just remember just looking at her as we're like riding this guy. Like, no, poor propofol. So, and she's like, I'm sorry. I'm like, I don't care. Just drop the propofol so you can put him to sleep. All right. Okay. They'll all be done in like 3 minutes. Cardiovascular, again, it's going to be very similar to the others. Mild myocardial depression, or depression of myocardial contractility, SVR, and arterial blood pressure will decline slightly less than with isoflurane and desflurane. Minimal increases in heart rate, so even when you overpressurize, you really don't see that. And interestingly, it may prolong the QT interval, and the clinical significance of that is unknown. But does anybody else know what other drugs might prolong the QT interval? You probably haven't gone through any of that. Zofran, right? And there are others also that will do that. Yeah, so you have to be careful with those because like droperidol, which was a great antiemetic, nobody gives it. We don't even have it now anymore because it prolonged the QT interval and this black box warning came up. You have to monitor your EKG beforehand. You have to get EKG afterwards. People just stopped using it. So, but if it's additive with that, it's kind of interesting. Depresses respirations, reverses bronchospasm similar to the others. Slight increase in cerebral blood flow and ICP. Okay, but it's slight. So we will use it in neurosurgery, but not a lot of it. Like I was telling you, usually we'll do a TIVA, propofol infusion, narcotics, and we'll run maybe a little bit. We always like crack the vaporizer around the SIBO as a background. High concentrations may impair autoregulation of the cerebral blood flow that we talked about, and cerebral oxygen requirements will decrease. It does relax skeletal muscles, and in a child, when you breathe the child down for a procedure, and you do an inhalational induction with this, they'll just sit there and they'll breathing slowly go off to sleep. After you get them deep enough, usually a MAC or more, oftentimes you can intubate them and the vocal cords will be relaxed, and it's enough to allow you to intubate without using supplemental muscle relaxants to do that, so that's kind of a bonus in some situations. Slightly decreases renal blood flow, decreases portal vein blood flow, and increases hepatic artery blood flow, so really total hepatic blood flow is really unimpacted. It's metabolized by liver microsomal enzymes. It causes a rise in inorganic fluoride, so there is some potential nephrotoxicity with this drug. Overall metabolism is 5%. And there's something called compound A. Have you guys heard about that? All right, that's something different about this drug. So this is something that I remember about this drug. Okay, of course you don't remember everything we talked about. So alkalis such as soda lime can degrade sevoflurane, produces a nephrotoxic end product called compound A, and that can accumulate, and accumulation will increase with increased respiratory gas temperatures, low flow anesthesia, meaning running very low minute volumes, and high SIBO concentrations and dry barrel line. So most of us, and Bill, I don't know if you do or not, I usually keep it at 2 liters or above.
Yeah, for me, I always just, when I have that, I just use it. Or utilizing SIBO, just 2 liters and
right, 2 liters per minute oxygen flow usually will clear that out. Other agents like desflurane and isoflurane, you can run really low oxygen flows, and it saves a lot of money because you don't use as much agent. You're not getting, higher oxygen flows, you're going to have more agent absorbed and sucked up, and you're going to use a lot more agent. So contraindications against severe hypovolemia, NH susceptibility, and intravenous hypertension. Okay, obstetric effects. Volatile agents produce similar and dose-dependent decreases in uterine smooth muscle contractility and blood flow. Okay, so if you're at 0.5 MAC, you're going to get some decreased uterine tone, and if you're a MAC or above, you're going to get a lot of decreased uterine tone. Okay, so when you do a C-section and the baby's delivered, what do they want the uterus to do? Contract. This will prevent that, or it will also. So typically, we will run maybe 0.5 MAC of a volatile and try to keep it below that, and most patients are going to remember anything like that. It can be good if there's retained placenta, because it will relax the uterus to allow them to get it out. but then when they're bleeding, you're not gonna get like as much effect for pitocin dose with that to cause contraction. All volatile agents will rapidly cross the placenta to the fetus, and typically a volatile anesthetic at about a half MAC combined with 50% nitrous oxide to ensure amnesia during a C-section does not produce really any detectable effects and symptoms. Okay, and then these are just a few more charts. We went over a lot of this. Again, the different agents and how they impact different systems. Okay, tidal volume, respiratory rate, cerebral blood flow, renal blood flow, etc. Very, very useful chart. You need to memorize that chart. All right, be very familiar with it. And again, this is just stuff I've already given you. That's in there for use. Okay, and we're done. 4 minutes late, sorry.
Good.